my topic was about the use of IVUS, intravenous ultrasound, in patients that have this chronic pelvic pain, pelvic venous disorders. I have no disclosures, so I won't go through the whole exam and imaging. We've heard about that. I will just say, Zaza, that I tend to put people on MPFF, and I also have the gynecologist try hormonal suppression, hormone-impregnated IUD or something like that. Many times their symptoms get better if they're pelvic symptoms, so that's one of those things I will do. So I guess just this slide, and then we'll kind of rush through to a case, and we'll be done. But basically, why not to use IVUS? How many people use IVUS? How many people have it in their office? Yeah, okay, well, I don't have it in our office because in the United States it's not covered in an office setting. You can have an OBL or an operating room where I use IVUS all the time. But it's a very expensive machine. It has expensive catheters, about $1,000 a piece, or maybe $600, $800 a piece. It has a larger sheath, so if I'm going from a jugular or ephemeral, I'd rather not have to use a 9 French sheath. But these are reasons why I don't use IVUS for everyone. It's also unclear when you do IVUS or any procedure, it's hard to know exactly what a significant stenosis percentage is. I don't think anybody knows it's 50%, it's 70%, it's whatever. It's also listening to the patient, as we've been talking about. Why to use IVUS? It's a very good complementary tool. When you have some suspicion, I always have it ready to use because I want to be able to get the best information I can, which I do believe we all feel it's a gold standard. I also use less x-ray time and less dye, so I think those are important things. This is a case, again, talk about a patient that had no pelvic symptoms, and she had her leg treated in another hospital. They actually didn't ask her about pelvic symptoms, though, I think, and talking about all this, having a good interview, that's so important because I think she probably did. She didn't say anything about it. She had radiofrequency ablation of her great saphenous vein, had some sclerotherapy of her labial vulvar area, and leg veins. She had 3 children, 3 pregnancies. A few years later, she came back with some recurrent veins and vulvar venous pain, one of my partners, and did not, again, get much in the way of proximal imaging, and she underwent some more sclerotherapy of her leg veins. Her symptoms in her legs improved, but her pelvic pain was still there, or maybe they thought new, and she came to me. So this was her vulvar area, which was certainly a lot better than it had been. Very few, but still a few varicosities there, and her legs looked pretty clear and were pretty asymptomatic. She had no edema, no claudication symptoms, no signs that maybe she would have obstruction. But I do get, now in the United States, we have a really good system of doing pelvic ultrasound like you showed, and we actually have specially trained technicians that are super ultrasound technicians. They work with us and I go in with them and then they learn how to kind of get this done. But this is a interesting thing. So we look at the diameter of the vein and the reflux at the point of obstruction and the reflux before or downstream from the obstruction. So we look at ratios as well. So for her, she had a very large ovarian vein with reflux going away from the kidney. The renal vein is also interrogated, and we look at the diameter and velocity ratios. And for them, if they're over 5 times faster or 5 times smaller, then we consider that a significant stenosis. This was 4.8 and 4.3 for those in the back. So this was a little bit tight, but we weren't sure. The iliac veins also were interrogated on the right and the left. There, usually that ratio is a 2.5, and these were, again, under 2.5, so I wasn't very worried about her iliac vein. But then we look at the image on the right. You can see the iliac being kind of pancaked along the spine and the right common iliac artery pressing there. And then you look at the flow pattern in the common iliac vein, and it was a little flat. So I was a little suspicious, and we thought, yep, this is a case that I need to use IVUS. So that's the kind of way I use it. Here's a confirmatory CAT scan. We're in the United States. Of course, you got to do everything. I almost went to the operating room without it, but we see some pelvic varicosities down deep in the pelvis. and down into her labial vulvar area, and we went right by the iliac, but it was definitely pancaked across, but not completely compressed. And this is in a supine position, a little dehydrated too. So again, decision making, we don't have to go through that too much more. I guess the one thing to think about though, if I'm going to use IVUS, am I going to go from the top? Do I think I'm going to need to use a stent? Or am I going to go from the femoral and come up and around? I prefer going from the top, but it is a little harder to do the stents from the top. But much easier with the new stents. The wall stent would shorten, and that was a lot harder to figure out how to get it to land right at the common femoral junction. So this is the right common iliac, which looked nice and normal. This is the left. Again, I came from the top, so this is a pigtail catheter. And you can see, obviously, the pancaking of the vein. Yeah, here, and you can see the collaterals coming across, so that was looking like it was somewhat suspicious. So again, I got the IVUS out, we changed it up to a 9 French sheath. And here's the IVUS. Now this right-hand picture where it's very narrowed is actually, that's not the best picture. They didn't save all of the images, unfortunately. But this was, it was at least 63%, probably tighter than that, between the open vessel and the closed vessel. And you can see the area's surface area. So IVUS is a very nice way to be able to measure that cross-surface area and compress. So, I guess, again, we don't have to go through there. I think many of us just feel, I think when you're going to do a stent, I feel like an IVUS, if you have it available, is the way to go. So again, the SVP classification, I don't have to talk about at all, but these are the things that she had, 2 and 3, A and B, for symptoms. She had location of varices in her abdomen, pelvis, her perineum, and her leg, a little. So she was a 2, 3, A, B. And then pathophysiology, these are the veins that were involved, so that's the anatomy. They were obstructive for the iliac and refluxing for the ovarian, and they were non-thrombotic. So this is her pelvic this is her SVP classification, and it really does read kind of from left to right. You can read it, and it tells you the story of the patient. So we can now, when we treat her, we can go back and say, anybody that was S1 did this, and anyone that's S2, 3, A and B is this. So it's kind of a good thing, like SEEP, that will put them in the right buckets, and we can make comparisons. So again, IVUS helped us to know what was going on. That iliac compression, I thought, was probably the most important thing. So we did a stent. It was a little bit kind of wrinkled in the middle there. So we ended up doing an IVUS to also compare and to look at the stent along the length. And you can see it's pretty open. We actually ironed it out a little more and stopped. So IVUS can help. And I think when you have both, I won't go through all this, but it's everything from if you do just if you have refluxing ovarian vein and iliac compression, which one do you do? This is the literature search that I did. One said 56% get better. One said it's better VAS scores with iliac stenting first. And this one said only 17% get better if you just stent them. You have to kind of do both. Now, again, I'm just going a little quicker, but this is her internal iliac vein that before I put the stent in, we actually did do a little bit of top-down sclerotherapy with a balloon occlusion catheter to get down into the varicosities, which did actually help her vulva significantly. I also did a quick look at the ovarian vein, but we decided that they do get very, very ill afterwards. I don't know if anybody does these things together, but they get a malaise and fever and post-embolization kind of feeling if you do sclerotherapy, embolization, and stents. So I tend to stage them, and I think that's okay, as long as you tell them ahead of time. And they're, so this, let's see, just sometimes they do take a while to resolve, and remember the placebo effect, don't rush back. And then again, we talked about multidisciplinary team. So follow-up, she's doing well, but still has a little bit of symptoms. We're going to wait and see. So don't use IVUS in every patient, but think about it and have it ready if you think you might need it. Merci.
Thank you, Julianne. Est-ce qu'il y a des questions?
Quick questions?
Sur l'IVUS. Wassim?
Thank you for your presentation. It was very interesting. I have a question. In this particular case, you used the venography and then IVUS. Could IVUS be performed instead of venography to avoid radiation to the patient?
Yes, potentially. We use very little radiation, but that was basically the only 2 runs that we did with the venogram. But the only time I really only use IVUS if a patient is pregnant. I like to be able to at least, especially figuring out the length of the stent and being able to, I think it's a nice way to kind of confirmatory, but not the only thing that I use when I'm doing it.
Thank you.
Thank you.